There is something I've been carrying around for a long time, something that sits uncomfortably in the space between what I know as a physician and what I watch happen to patients every single week. And I have decided I am done staying quiet about it. I know that the moment I say this out loud, some of my colleagues are going to be uncomfortable. Some of them are going to push back. There are systems built around the thing I am about to question, entire industries organized around it, and I understand that. But after more than 20 years of practicing medicine, after sitting with patients who came in healthy and left worse off, I cannot keep choosing professional comfort over honest conversation. Here's the thing that nobody in medicine seems willing to say plainly. Sometimes the single most damaging thing a person over 60 can do for their long-term health is agree to too many medical tests. I know how that sounds. I know you have been told your entire adult life that catching things early is everything, that finding problems before they become serious is the whole point of preventive medicine, that a responsible patient is a patient who stays on top of every screening, every checkup, every recommendation that lands in their inbox or gets suggested at their annual physical. That message is everywhere. It is in the television commercials for imaging centers. It is in the pamphlets on the waiting room table. It is delivered with absolute confidence by nurses and technicians, and sometimes by physicians who genuinely believe they are doing the right thing. But that message is missing the most important chapter of the story, the chapter about what happens after something gets found. My name is Dr. William Madison. I have been in clinical practice for over 2 decades, and today I am going to walk you through 5 medical tests that I believe cause more measurable harm than benefit, specifically in adults over 60. Not because I want to frighten you away from doctors, not because I think medical testing is inherently dangerous, but because I think you deserve to understand the full picture of what you are agreeing to before you say yes. And right now, most people are saying yes without any idea what they are actually signing up for. Before I name the first test, I need to give you a framework, because without this framework, none of what follows will land with the weight it deserves. In medicine, we call it the cascade, and once you truly understand how it works, you will never walk into a screening appointment the same way again. Here is the cascade. You are feeling well, no symptoms, nothing obviously wrong. You go in for a test, either because it was recommended, because you saw an advertisement, or because the idea of not knowing what is happening inside your body feels more frightening than knowing. The test comes back and the report mentions something. It might be a shadow, a nodule, a measurement sitting slightly outside the normal range. The radiologist flags it as something requiring follow-up. Now the machinery starts moving. Your doctor sees the finding and they are professionally, and in many cases legally, obligated to act on it. They refer you to a specialist. The specialist, wanting to be appropriately thorough, orders a more detailed test. That test shows the same ambiguous finding, still not clearly definable. Now a biopsy is discussed, or a procedure, or in some cases, surgery. And every single step along that road carries its own risks. Infection, bleeding, complications from anesthesia, anxiety that follows you home every night and wakes you up at 3 in the morning for months, lost time, lost confidence, a permanently altered sense of your own body. And then, in the overwhelming majority of cases, you reach the end of that road and find out it was nothing. The finding was never going to cause you any harm. It was a biological footnote that the medical system turned into a headline, and you paid the price for that in ways that are difficult to fully measure, but very easy to feel. That is the cascade. And it does not begin with a diagnosis. It begins with a test. A single, well-intentioned test that generated a finding that required a response that led somewhere the patient never needed to go. The question I want you to carry into every future medical conversation is not simply, should I get this test? The question is, what happens to my life if this test finds something? Because those two questions lead to completely different conversations, and the medical system almost universally only helps you answer the first one. The first test on this list is one that has been growing in visibility and in marketing reach for the better part of a decade, and its pitch is genuinely compelling. I understand why people respond to it. I am talking about whole body scans. Full body MRIs or CT scans offered by private imaging centers with the promise of a complete internal picture, a comprehensive look at everything happening inside you, from your skull to your pelvis, all in one visit. The advertising for these services is psychologically sophisticated. It speaks directly to the anxiety that most adults carry quietly as they age, the fear of the unseen threat, the silent danger developing somewhere inside you that has not announced itself yet. The scan promises to remove that uncertainty, to hand you knowledge, to give you control over something that normally feels completely out of your hands. Here is what the advertisement does not tell you. When researchers scan healthy adults over 60 with no symptoms, no family history flags, no clinical reason for concern, they find something that requires radiological follow-up in somewhere between 85 and 95% of cases. Not because those people are sick, because that is simply what human bodies look like from the inside after 6 or 7 decades of living. The medical community has a specific term for these findings. They are called incidentalomas, things found by accident, findings that were not the object of the scan but showed up in the image and now, by the rules of medical practice, cannot be ignored. A 3 mm nodule in the lower lobe of the right lung, a small cyst noted on the left kidney, a spot on the liver that is almost certainly benign but cannot be confirmed as benign without further investigation. Now picture yourself as the person who walked into that imaging center, feeling perfectly healthy, and walks out holding a report with that language in it. Picture trying to take a deep breath over the next 3 months without thinking about what is sitting in your lung. Picture explaining to your adult children why there is a follow-up appointment scheduled. Picture the specialist visit, the more detailed scan, the biopsy recommendation, the conversation about anesthesia risks, and then picture the call, months later, where you are told it was scar tissue from an old infection. It was always scar tissue. It was never going to do anything to you. The research tracking outcomes for people who received whole body scans compared to people who did not produced a finding that should be part of every advertisement these imaging centers run. The people who got scanned did not live longer. They did not avoid disease at higher rates. They did not benefit measurably from knowing. What they did experience, at significantly elevated rates compared to the unscanned group, was anxiety, depression, and unnecessary invasive procedures. The scan did not make them healthier. In a measurable, documented sense, the scan made them less healthy. What is the alternative to a whole body scan? Functional assessment. Not a picture of what your insides look like, but an honest evaluation of what your body can do. Can you walk up 2 flights of stairs without stopping to catch your breath? Can you stand up from a chair without pushing off with your hands? Can you maintain your balance standing on 1 foot with your eyes closed? How is your sleep? How is your energy across the day? These are the measures that actually predict health trajectory in older adults. They reflect biological reality in a way that a static image of your anatomy simply does not. If you want a genuinely useful medical checkup, find a physician who will sit with you for long enough to go through every medication you are currently taking. Because I can tell you from experience that in most patients over 60, at least one of those medications is creating more problems than it is solving. Find a physician who will talk with you about your daily movement, your diet, your social connections, your sleep quality. These are the boring, non-scannable, non-billable factors that actually determine how long you live well. The scan is searching for problems that may not exist. The functional assessment is protecting the health you already have. The second test touches something far more personal and emotionally charged, and I want to approach it with the care it deserves. I am talking about brain MRIs ordered in response to what are, in the overwhelming majority of cases, completely normal age-related changes in memory. Here's the scenario. You are 73 years old. You have started noticing that names take slightly longer to surface. You walked into the bedroom last week and stood there for a moment, genuinely uncertain why you had come in. You lost the thread of a conversation at dinner. Your family is worried. Your daughter has been reading about Alzheimer's and the fear is written on her face at every family meal. So she asks you to get a scan. Just to be sure. Just to rule it out. And I understand that fear. I want to be unambiguous about that. The fear of losing your mind, of losing yourself to a disease that takes the person away long before the body follows, is one of the most profound fears a human being carries. Your family loves you, and they are terrified. Of course they want answers. But here is what that brain MRI will almost certainly produce, and why it will almost certainly make things worse rather than better. You get the scan. Several days later, you sit with your doctor and go through the report together. And the report is full of language like this. Mild cerebral atrophy consistent with age. Scattered periventricular white matter changes. Small vessel ischemic disease. Mild volume loss in the hippocampal region. Every one of those phrases sounds like a description of a brain in serious trouble. They sound clinical and alarming and permanent. And I have watched patients absorb that language and fundamentally and irreversibly change how they see themselves. Watch people who are genuinely sharp, who are managing complex financial decisions, reading challenging books, maintaining rich social relationships, suddenly begin carrying a story about themselves that said something was wrong with their brain. That story, once established, is extraordinarily difficult to dismantle. Here's what that language actually means. It describes the entirely normal, entirely expected appearance of a 73-year-old brain. Every single finding in that report falls within the range of what researchers expect to see when they image the brain of a healthy older adult. It is the neurological equivalent of a dermatologist scanning a 73-year-old's skin and noting wrinkles, age spots, and reduced elasticity. Of course, those findings are there. That is what skin looks like at 73. It is not disease, it is age. The research on this is not subtle. When scientists perform brain MRIs on cognitively healthy adults over 75, people who pass every standard memory assessment, people who live fully independently, people whose families describe them as sharp and engaged, more than 90% of those scans contain findings that look abnormal on a radiology report. More than 90%. And the great majority of those people will never develop dementia. The image and the clinical reality do not correspond the way we wish they did. I have sat with patients in their late 70s whose cognitive function was genuinely excellent in every measurable way, and whose MRI reports read like a cause for serious concern. I have also sat with patients in early cognitive decline whose imaging looked relatively unremarkable. The picture does not predict what we want it to predict. And attaching alarming clinical language to the brain of a healthy older adult causes psychological harm that the scan was never supposed to cause. What should happen instead, when memory concerns are real and genuine, is a functional cognitive assessment. It takes 10 minutes and it can be done in any clinical office. We ask the patient to remember 3 words and recall them after a brief delay. We ask them to draw a clock face showing a specific time. We ask them to perform a brief sequence of cognitive tasks. These tests measure how the brain actually performs, not how it looks in an image. And performance is the thing that matters. And here is the piece of information that I consider genuinely important for anyone worried about an aging parent's memory. The most common causes of memory impairment in adults over 60 are not structural. They are functional. Medication side effects, and the list of medications that impair cognitive function in older adults is longer than most people realize. Vitamin B12 deficiency, which is remarkably common and remarkably easy to miss in standard blood panels. Depression, which in older adults frequently manifests as cognitive fog rather than visible sadness. Undiagnosed sleep apnea, silently reducing oxygen delivery to the brain for 8 hours every night. Thyroid dysfunction. These causes are treatable. In many cases, they are completely reversible. Not one of them will be identified by a brain MRI in a way that helps you fix it. A brain MRI for progressive, significant, functionally impairing memory decline is an appropriate and important diagnostic tool. I am not suggesting otherwise. But for the ordinary, age-appropriate forgetfulness that families are understandably frightened by, the scan creates a problem it was never equipped to solve. The third test surprises people when I bring it up because on the surface, it seems like the most logical thing in the world. I am talking about routine cardiac stress tests, specifically treadmill tests ordered not because a patient has symptoms, but because they have crossed an age threshold and a protocol box needs to be checked. Here's a scenario that unfolds in hospitals across the country every single week. A patient in their early 70s is preparing for a routine elective procedure, a knee replacement or a hernia repair, nothing that carries significant inherent cardiac risk. The pre-surgical checklist requires a cardiac stress test for anyone over a certain age, so the patient, who walks several miles each week without chest pain, without shortness of breath, without dizziness or palpitations, gets on a treadmill. Stop and consider what that test is actually measuring. It is asking whether this patient's cardiovascular system can handle physical exertion, and this patient answers that question every morning when she takes her walk. Her daily life is already a continuous real-world stress test, and she passes it without incident every single time. The treadmill is not going to tell us anything her body is not already communicating through her daily function, but the protocol requires the test, so the test happens. And here is where the cascade begins. Cardiac stress tests in adults over 70 carry a high rate of false positives. The test generates an abnormal result not because a dangerous coronary blockage is present, but because of age-related changes in how the heart responds to exercise, or because of medications the patient takes that affect heart rate and electrical activity, or because of normal baseline variations in the electrical pattern of an aging heart. The test reads as abnormal. The cardiologist is now obligated to respond. A cardiac catheterization is scheduled. This is an invasive procedure in which a thin, flexible tube is threaded through an artery, typically at the wrist or groin, and advanced all the way to the coronary arteries surrounding the heart to examine them directly. It requires sedation. It carries real procedural risks, including arterial damage, kidney injury from contrast dye, bleeding, and in rare cases, stroke. And when the procedure is complete and the images are reviewed, the findings are almost invariably what anyone with basic cardiovascular knowledge would expect to find in the arteries of a healthy 72-year-old. Some plaque accumulation, some degree of narrowing in one or more vessels. The kind of changes that accrue across a lifetime and are being managed successfully by an active lifestyle and normal cardiac function. Nothing requiring stenting. Nothing that was preparing to cause a heart attack. Nothing that would have changed this patient's clinical management in any meaningful way. But now something has changed that cannot be unchanged. She has been through an invasive cardiac procedure. She has been placed on additional medications. She has been labeled, in her medical chart and in her own understanding of herself, as a cardiac patient. And the most damaging consequence of all is one that no procedure note will capture. She was playing tennis twice a week before this process began. She has not been back to the court since, because now she is afraid. The test that was supposed to reassure her about her heart has taken from her the physical activity that was protecting her heart most effectively. That is the real cost of an unnecessary cascade in a healthy older adult. Not a complication rate in a data table, an actual person who stopped doing the thing that was keeping her well. What should happen instead? Listen to what the body is already saying. The most meaningful cardiac data available to any physician is the symptom profile a patient reports from their daily life. Chest discomfort that appears with exertion and resolves with rest. Shortness of breath disproportionate to the level of activity. Unexplained dizziness. Palpitations that feel different from anything experienced before. These are symptoms that warrant investigation. Their absence, in a patient who is physically active and functional, is genuinely informative data. If objective risk quantification is clinically appropriate, the tool I would point to is the coronary artery calcium score. A brief, low-radiation CT scan that produces a single number representing the amount of calcified plaque present in the coronary arteries. A score near 0 indicates very low near-term heart attack risk. A high score indicates elevated risk that should drive serious preventive action, lifestyle modification, medication discussion, closer monitoring. But the calcium score informs and guides. It does not automatically initiate a procedural cascade. It gives the patient and physician information to work with, rather than a finding that forces a sequence of interventions the patient may not need and cannot easily stop once started. The fourth test is where I expect the most pushback, and I want to be careful to say exactly what I mean and exactly what I do not mean. I am talking about routine colonoscopy screening in patients over 75 who have no specific clinical risk factors and whose previous colonoscopies have been normal. Let me be direct about what I am not saying. Colonoscopy is one of the most effective cancer prevention tools in modern medicine. The ability to identify and remove precancerous polyps before they progress to colorectal cancer is a genuine and significant clinical achievement. I recommend colonoscopies. I have referred hundreds of patients for colonoscopies. If you are in your 50s or early 60s and you have not had one, please have that conversation with your physician immediately. The benefit is clear, and the risk is manageable at that age. But medicine is not a collection of universal rules that apply identically across all ages and all bodies. Medicine is a continuous, individualized recalibration of benefit against risk. And that recalibration, when applied honestly to routine colonoscopy screening in patients past their mid-70s, produces a different answer than most people have been given. The benefit of a screening colonoscopy is the prevention of a colorectal cancer that, if it develops, typically takes 5 to 10 years to become life-threatening. That is the temporal window we are working with. For a 65-year-old with decades of anticipated healthy life ahead, that window makes a routine screening colonoscopy clearly worthwhile. Detect a polyp today, prevent a cancer that would cause serious harm in 10 years when the patient is 75 and has every reason to want to be living well. For an 81-year-old patient whose last colonoscopy at 71 was completely normal, that calculation looks fundamentally different. The cancer we are hypothetically trying to prevent would take until the patient is in their early 90s to become a genuine threat. And the procedure designed to prevent it carries risks that escalate significantly with age. The bowel preparation required before colonoscopy involves consuming large volumes of purgative liquid that produce substantial fluid and electrolyte loss. In younger adults, this is deeply unpleasant, but physiologically manageable. In older adults with reduced physiological reserve, it can cause clinically significant dehydration and metabolic disruption. The sedation required for the procedure carries meaningfully elevated risk in patients over 75, including heightened likelihood of post-procedural confusion, respiratory depression, and hemodynamic instability in patients with underlying cardiovascular conditions. And then there is the complication that sits at the front of every experienced gastroenterologist's mind when scoping an elderly patient: perforation. As the colon ages, its wall becomes progressively thinner and less resistant to mechanical stress. The risk of the endoscope causing a tear in the colon wall roughly doubles or triples in patients over 75 compared to younger adults. A colonic perforation is not a minor setback. It is a surgical emergency requiring immediate operative intervention, frequently under general anesthesia, often resulting in a temporary or permanent colostomy. For an 80-year-old patient, emergency abdominal surgery under general anesthesia is a catastrophic event with its own substantial mortality risk and a recovery trajectory that, even in favorable outcomes, permanently alters the patient's functional independence. Weigh that against preventing a cancer that would take 10 years to become life-threatening. The mathematics are not comfortable, but they are honest. Major medical guideline bodies, including the American Cancer Society and the U.S. Preventive Services Task Force, have recognized this explicitly, recommending that routine colorectal screening stop somewhere between 75 and 85 for average-risk adults, with individualization based on health status and life expectancy. This guidance exists. Most patients over 75 have never heard it. What does appropriate colorectal vigilance look like after 75? First, it means being genuinely attentive to symptoms, not waiting passively for something to feel wrong, but actively knowing what to watch for. Persistent change in bowel habits that does not resolve. Blood in the stool that appears more than once. Unexplained abdominal pain or significant unintended weight loss. New anemia with no identified cause. These are signals that demand investigation regardless of age and regardless of prior screening history. They are not things to manage with dietary changes or to mention casually at the next annual visit. They require prompt attention. Second, it means taking seriously the most powerful, non-invasive tool available for colorectal health at any age: dietary fiber. Not as a supplement, not as a processed additive, but as whole food. Vegetables, legumes, whole grains, fruit. Dietary fiber feeds the populations of beneficial bacteria in the large intestine that produce short-chain fatty acids, compounds that actively suppress colonic inflammation, support mucosal integrity, and create a biological environment hostile to the development of precancerous cells. This is not alternative medicine. This is established gastrointestinal microbiology with decades of supporting research. And unlike a colonoscopy, eating more lentils and broccoli carries a risk profile of exactly 0. Now let me bring all of this together, because the pattern connecting all 4 tests is worth naming clearly. Whole body scans that generate findings requiring follow-up in nearly every person over 60 who receives one. Brain MRIs for age-appropriate memory changes that attach frightening clinical language to normal biology. Routine cardiac stress tests that produce false positives at high rates in older adults and deposit patients onto procedural conveyor belts they never needed to board. And colonoscopies past 75 that carry escalating procedural risks against a benefit window that may no longer be clinically meaningful for that individual patient. The thread connecting all 4 is the cascade, the self-perpetuating sequence that begins with a single test, proceeds through a chain of findings and responses, and ends somewhere the patient never needed to go, often worse off than when they started, and always having paid a price that was never disclosed in the original recommendation. Here's what I want you to understand about why this matters beyond the individual clinical scenarios. Health at 65 or 70 or 80 is not a test result. It is not a scan finding or a radiological report or a number generated by a laboratory. Health is functional. It is the daily experience of being able to do the things that make your life meaningful. Walking somewhere you want to go, engaging with people you love, sleeping and waking with energy, reading something that moves you and remembering it later, carrying your own groceries, making your own decisions. The medical system is extraordinarily good at finding things. It is considerably less focused on asking whether finding them makes the person who has them actually better off. And that question, the most important question in all of medicine, is the one that you are now equipped to ask. When a test is recommended, ask why. Ask what the test is looking for and what the probability is that it will find something. Ask what happens if it finds something. Walk through the cascade step by step before you agree to step 1. Ask whether there is a functional alternative that gives meaningful information without the downstream risks. Ask whether the benefit of this specific test, for a person of your specific age and health profile, genuinely outweighs what the cascade might cost you. These are not rude questions. They are not the questions of a difficult or non-compliant patient. They are exactly the questions that good physicians welcome, because they are the questions of someone who understands that medicine is a partnership, and that informed patients make better decisions than passive ones. The goal of all of this is not to live longer at any cost. The goal is to live well, with independence, with engagement, with the quiet confidence that comes from understanding your own health, rather than being managed by it. Sometimes the most powerful thing you can do for that goal is to say, not this test, not for me, not right now. If this conversation shifted something for you, if it gave you even one question you did not have before you started watching, I want to ask you to do something simple. Think of one person in your life over 60 who agrees to every recommended test without asking why. A parent who nods along in every appointment. A friend who came home from a routine scan holding a follow-up referral they do not know how to think about. Someone who has never been given the information to ask the right questions. Share this with them, not to frighten them, not to turn them against their physicians, but because the most valuable thing you can give someone navigating the medical system at 60 or 70 or 80 is the knowledge of what to ask before they say yes. I'm Dr. William Madison. Your health is worth understanding fully, not just managing reactively. Take care of yourself, take care of the people around you, and I will see you in the next video.